Hello, leaders. Welcome to day 4 of the Atti Naomi Global Leadership Fellowship Cohort Training for Trainees, Tier 1. I'm so proud of how far you've come. Today, we're diving into a subject that lies at the heart of everything we do in public health, which is health equity and social justice. By the end of this session, you'll not only understand these concepts, you'll be ready to apply them directly in your final capstone project. I'm not showing my face today, just my voice. I remain Dr. Omomoimi Emanuela Agbeha, the founder and executive director of Atti Naomi's Foundation. I want you to focus on the message, so grab your notebook and let's journey together. And as you're doing that, in the comment section, I want you to write one sentence on what health equity personally means to you before we begin. I know in the introductory training course, we talked about equity. So tell me, what does that translate to you personally? Picture this. 3 children of different heights trying to watch a football game over a fence. If I give each child the same sized box, each of them measuring 6 inches tall, I have practiced equality because I didn't consider the fact that there might be a child that's as tall as 4 feet compared to a child that's as tall as 6 feet. The 4 feet will not be able to see over the fence even if I give him a 6 inches box, depending on how tall the fence is. On the other hand, if I give each child the number of boxes they need to see over the fence, I would have practiced equity. For example, if I give the 6 feet child 1 box to stand on, I would give the 5 feet child 2 boxes to stand on. Now that is equity because I want to ensure that all of them can see equally. But I'm not giving them the same number of boxes. Now, translate this to healthcare. If we give everyone the same clinic hours, but some people can't take time off work, we've practiced equality, not equity. Equity always asks, what does each person truly need to thrive? What does each individual need to survive? What does each community need to succeed, to be stable? When I started at Naomi's Foundation, I saw this firsthand in riverine communities as compared to communities on land. We offered the same free medical camp to everyone. Although mothers, infants, and residents in riverine areas could not cross the water to come to land to get care. So we shifted our model, right? That's why we started the Creek Health and Wellness Initiative. We thought about why not bring this clinic to them on a boat. So we took the clinic to them by boat. That was equity. Meeting people where they are. As volunteers, as change makers, as leaders, as public health professionals, we must move from sameness to fairness. So you're not looking at, we're giving them the same thing, but is it fair? So in your own words, I want you to write on the comment section. Describe one situation in your community, in your country, where people were treated equally, but not equitably. So describe a situation where people were treated equally, but not with equity. Let's go deeper. We often hear the words disparities and inequities, but they mean different things. Health disparities are differences that we observe. For example, if the infant mortality rate is higher among Black women, right? That's a health disparity. But health inequities reveal the unjust reasons behind those differences. For example, racism, poverty, or lack of quality care. As a pharmacist, I saw countless hypertensive patients who couldn't afford consistent medication. their blood pressure wasn't high because they didn't care. It was because systemic poverty made essential drugs unaffordable. So that is not a lifestyle choice. It is a structural inequity. And I remember counseling an elderly patient who rationed her insulin. She told me, "Oh, I stretch it because my money isn't enough, my pension isn't enough." That moment taught me that behind every statistics is a story of injustice that we can change. So, change makers, can you mention one health disparity you've seen in your community and what you think causes it beneath the surface? So, you want to look at the health disparity and the health equity, the reason behind it. What's that difference that you see in your community compared to other communities? And what do you think caused it? You can write that in the comment section. I know we've talked about this before, the social determinants of health, but we're going to dive deeper. At least now we know that they are the non-medical factors that shape the outcomes of health. For example, where people live, learn, work, and play. There are 5 major categories of the social determinants of health. First is economic stability. Second, education. Third, social and community context. Fourth, health care access. And the 5th one is neighborhood and environment. In the Creek Health and Wellness Initiative, our floating clinic met families who hadn't seen a group of community health professionals in years. Not because these families didn't want to, but because no road led to a good health facility. Their health determinant wasn't medicine in this case, it was the geography, right? We can act at 3 levels. So we can divide this acting on social determinants of health at 3 levels. We have the downstream, the midstream, and the upstream. So downstream, we treat individuals. It includes health education, just like what we're doing now. We're educating you so you can educate people in your community. Screenings, and that's one of the major things that we do at Naomi's Foundation. Like I said, would rather prevent a damage than control a damage. Right? Prevention is better than cure. Then there's the midstream. So this is done to strengthen our communities. We could have clinics. This is now if we build a full-blown clinic. We could have nutrition programs. Again, think your capstone project. Think, how do you want to do this? Are you educating people? Are you doing nutrition programs? Right? Any healthcare programs, anything, even finance programs that would directly or indirectly affect health. Now there's the upstream where we want to transform the systems entirely. And that's where we talk about advocacy policies. We talk about the wages. Do we increase the income for the community? Do you have the right, as many of you here, I see your top leaders in your community, you work with the government. Can you make that change? Can you put in that policy? Can you ensure that people get the right income? Are there anti-discrimination laws to see that people are not discriminated because of their tribe, their ethnicity, or their color, or even their gender? So if your project only works downstream, it might relieve symptoms but not cure the cause. So that's why when you're thinking of any project, you want to think about the downstream, the midstream, and the upstream. Equity-driven leaders design interventions that touch all 3 levels. So again, I want you to comment, what level does your capstone project address right now? I know by this time, this is day 4, you should have been following the classes and you should know what your capstone project is. So would you say your capstone project is at the downstream level, the midstream level, or the upstream level? And how might you expand it to include another level. So we want to see that, yes, we know you might have a particular focus, a particular level that your capstone project focuses on, but I want to see your creativity here. How can you ensure that you have a little bit of the other streams? So if you're upstream, how can you ensure that there's a downstream and midstream and vice versa? Now, who suffers most from inequities? We call them the vulnerable populations. Not because they are weak, but because systems make them so. They include people in poverty, women and girls, racial and ethnic minorities, LGBTQ plus individuals, migrants and refugees, people with disabilities or chronic diseases, the elderly and incarcerated individuals. So, I also have an experience while serving as Miss Sion and also in my capacity as the director of Atti Foundation, right? I visited some clinics where teenage mothers were treated with disdain, or should I say homes, simply because they were unmarried and they became pregnant out of wedlock. They avoided care and their babies suffered. That's not vulnerability, that's exclusion. But yes, we tag them as vulnerable populations because these people are supposed to be treated, not excluded because of they became pregnant in their teenage age. In fact, they needed more, right? As the founding president of Delta Omega's Esselumzai chapter here in the States, I emphasize this point to our members. Health leadership must include voice representation, not just me, everybody in the community. So if you don't know about Delta Omega, it's an honorary society for public health, and for my school where I founded it, it included students from different parts of the world. We ensured that everybody was represented, from India, Nigeria, Ghana, the United States, name them, Lebanon, as far as every student in that community is represented, male and female as well. If the affected community isn't in the room, the solution is not complete. So you want to ensure that everybody, look at your stakeholders for your capstone project. Look at your stakeholders. Are you also talking to the vulnerable population, or you're just talking to the state leaders? No, they might not know where it really hits. They don't know the actual problem. They don't know the actual they don't really know what's going on, right? So I want you to comment, name one vulnerable population that your project focuses on and one specific barrier that they face. So you're going to name one vulnerable population your project focuses on and one specific barrier that they face. Now, just like I told you, we're all about practical. People talk about theory all the time, but now we want to connect the theory we've learned to your capstone. By day 4, that's today, your project should be clearly rooted in equity-focused design. So I'll give you 6 guiding principles. I like to call them the equity compass, First, identify the most affected. Don't design your project for everyone. Focus on those with the least advantage. In Atti Foundation, we begin every outreach by asking, who is invisible here? Who are those people that we don't see, right? Second, understand the root causes. Ask why repeatedly until you reach the real issue. Is it poverty, stigma, or lack of transport? Remember your 5 whys? Yeah. Thirdly, involve affected communities. So if you want to hire them, if you want to train them, or co-create with them, you want to co-create your projects with them. Go if you want to work with the teenage girls in your community or the young boys in your community. What do they need? Involve them. In the Creek project, we involved local boat drivers because we knew we're going to go by boat to those locations, right? And we didn't have a driver at that point in time, and we didn't understand the terrain so well. So we included them in our project. They became our health navigators. Fourthly, you want to address multiple levels. You remember what we said about the downstream, midstream, and the upstream? So you want to educate individuals, you want to mobilize communities, and you want to be able to influence systems, right? The fifth is you also want to be able to challenge systemic barriers. You want to speak truth to power, write the policy brief, even if it doesn't get to the government, let us have it. You want to partner with local leaders, your community, the chief of your clan, the king of your clan. And last but not the least, you have to monitor. I always say that you have to document. Nothing is complete without documentation. Another thing I always say is you can't work alone. You have to work with people, right? Track who benefits and who doesn't benefit. So you can come back and say, oh, after this fellowship program, we saw that 3 people benefited from Botswana, 70 people that benefited from South Africa, 100 people benefited from Nigeria. And we want to disaggregate our data by gender. So you want to know, is it mostly the males or females that benefited? And what age group? Is it mostly people between the age of 18 to 21, for example, for us, or between the age of 18 to 25? Did you hit your target? And their income level. Is it mostly students? Is it people that are working? Is it professionals, master students, PhD holders? I'm using that as an example. If you practice these 6 principles, your project won't just help people, it will transform structures. So I'm giving you what I use for you to use it. It becomes a structure, it becomes a guide. When you do yours and it's successful and you have even mistakes, it's still a success because somebody's going to learn from your mistakes, right? So in the comments, I want you to pick one of these 6 principles from identifying the most affected, understanding the root cause, involving affected communities, addressing multiple levels, challenging systemic barriers, and monitoring for equity. Pick one of them and share how you apply it in your projects. Here's your quick capstone equity checklist. So you want to identify the vulnerable group, map the social determinants behind your health issue, explain how you involve the affected community, clarify which intervention levels you'll address, create an evaluation plan, how you measure impacts on equity, ensure your approach is culturally respectful. That's something that's to be emphasized again. You want to ensure that it's for the population. You're doing the right things for your population, right? Another example I'll give is Atamis Foundation can be carrying out an anti-malaria campaign in the US because it's not culturally suitable for the United States citizens. Rather, we'll do that for Nigeria. That's just one typical example. So I just want to share something personal. When I first started working in pharmacy practice, I thought my job ended when I handed a patient their medicine, and talked to them. This is how you're supposed to take it. But just quickly, one day, a grandmother returned after a week. Her blood pressure was higher than before. And she whispered to me, "We're already friends." I stopped taking my medication because I couldn't read the label. That moment changed everything for me. Health equity begins not in policies, but in empathy. And this was during my internship, right? So you go through a series of internship, from 400 level. And I begin to see that equity begins not in policies, but in empathy, the ability to see what others cannot tell you. That's what inspired my journey into public health. And even it's part of why I created this fellowship. To raise leaders who not only heal bodies, but can heal the systems. So fellows, as you move toward your final capstone, ask yourself, Who benefits from my solution? Who is left out? What can I do differently to make my project more just, inclusive, and sustainable? Remember, every outreach, every policy, every data point represents a human life, and you have the power to rewrite that story. So for your final comment prompt, I want you to write what's one concrete change you will make this week to strengthen equity in your capstone. Thank you for listening and for committing to a world where health is a right, not a privilege. Until next time, keep leading, keep learning, and keep creating ripples of justice.